Hello, everyone. I'd like to welcome you to today's webinar, Ocular Manifestations and Eye Surgery Considerations in Patients with EDS and HSD with Dr. Jefferson Doyle. My name is Sarah Jo Ritchie. I am the volunteer coordinator at the Ehlers-Danlos Society, and I'm your moderator today. This webinar is a part of our ongoing series, Living with EDS and HSD. So this is how today's webinar is going to work. Webinar attendees will be muted at all times during the webinar. However, you are able to type any questions that you may have throughout the entire presentation into the question box at any time. Now, Dr. Doyle will not be able to see or respond to any questions until the Q&A portion at the end of their presentation. Please do not send your questions more than once. It will not increase your chances of having your question answered. It will only make it harder for us to sift through the questions and get to as many as possible. Now, Dr. Jefferson Doyle specializes in pediatric ophthalmology and genetic eye diseases. He is an assistant professor of ophthalmology and genetics at Johns Hopkins, and serves as co-director of the Wilmer Eye Institute's Genetic Eye Disease Center. His clinical interests include Marfan syndrome and related connective tissue disorders, pediatric retinal dystrophies, pediatric cataracts, glaucoma, and other anterior segment anomalies. Dr. Doyle has published a number of genetic disorders over the past decade and has given multiple national and international talks. His main research focus is understanding the genetic causes and molecular mechanisms driving genetic eye diseases and utilizing that knowledge to develop new treatments. He has played a significant role in advancing our understanding of Marfan syndrome and related connective tissue disorders, and he holds 2 patents for novel therapeutic strategies to treat them. His work and that of collaborators has led to the discovery of the genetic causes of, I'm going to butcher this one, Sprintzen-Goldberg syndrome and Loeys-Dietz-like syndrome. Part of his current work focuses on the identification of modifier genes that protect people from developing genetic disorders and targeting those genes for therapeutic intervention. He also has an interest in syndromic and non-syndromic forms of high myopia and has ongoing preclinical studies evaluating the mechanisms that drive it and novel therapeutic strategies to ameliorate it. Thank you so much for being with us today, Dr. Doyle.
Sarah Jo, thank you ever so much. It's an honor to be here. If we have hit any technical problems, please do let me know. I can always switch over to my phone audio if I need to. But otherwise, hopefully everything goes smoothly. So I'm delighted to be talking on exactly as you described. So eye manifestations and consideration with regards to eye surgery in patients with EDS. I have a couple of disclosures to make. Sarah, you made mention of the patents. I do some consulting as well related to genetic eye diseases, but nothing directly related to today's talks. And so really 2 broad topics I wanted to discuss today. So first of all, the common eye manifestations seen in EDS patients. I was going to touch upon the published literature. I always feel that EDS patients are incredibly well informed about their condition and what's going on. And so I don't want to spend too long on this because I feel as though a lot of people will know a lot of this anyway. But then given the number of patients that we see in clinic, I think you start to see patterns of more unusual things that I don't necessarily see published in the literature a lot. I thought I might touch upon some of those, and partly as well actually to get feedback from people who may be listening or who want to reach out to me afterwards to say, oh yes, it's interesting you say that. I have something similar. I feel as though that happens a lot of the time with these talks. And then the second part is to just discuss the surgical considerations for EDS patients and for any of their physicians that might be listening, again, touching upon the published data and then also personal experience of certain things that I haven't seen published, but that I'll be interested to know if others have come across as well. So in terms of obviously EDS being such a broad category of a number of disorders, I thought I would first touch on the kyphoscoliotic, more because I wasn't going to dwell too much on this. I wanted to talk more on some of the other conditions. And so ocular features including, as many will know, so blue sclera, which is seen fairly commonly, so microcorneas, essentially a cornea that is smaller than normal, so the cornea being the clear part of the eye at the front of the eye. That in itself is not necessarily a problem as long as the cornea is clear, although sometimes it can be indicative of an anterior chamber. So that's really the cornea and the front part of the eye as one looks into the iris, which is the colored part of the eye. The drainage system that allows fluid to flow out of the eye can sometimes be a bit smaller. So that can in itself predisposed to a certain form of glaucoma where the fluid flowing out of the eye gets restricted. Other features include refractive issues, so high myopia, certainly something we see, as well as scleral fragility in more of a minority of patients, as well as a number of retinal issues and glaucoma have also been reported. In terms of a general recommendation, we'll typically say if someone is stable and doing well, then an eye exam at diagnosis and then regular follow-up for the potential things that can happen is normally a good way to go in these patients. Obviously, if there's something more acute, then we deal with it as and when is needed. In terms of the eye features of classic EDS, so there's a number of publications out there. I tend to sort of break things down into, let's say, structural, so anatomical changes that may be visible or not, compared to more functional changes that can occur. So in terms of, there are a number of structural changes that have been identified. This was one example of a publication that actually broke down the incidence of different eye manifestations into pediatric cohorts as well as adult. And you'll see that in a number of cases, these features can be prominent more as a younger patient, and then they tend to fade over time as the facial structure and features mature. But epicanthal folds, which are folds of skin, there's different types, but they typically folds of skin that can come over the eyelid, either above, below, or various other things. Ptosis, which is essentially a drooping of the eyelid, so that the eyelids can droop down. That can be one-sided, unilateral, bilateral, both sides. It can be bilateral but asymmetric, particularly in young children. We worry about if one eyelid is drooping and covering the visual axis, the problems that that can cause, although a lot of the time it's present later. And patients may need surgery to help raise the eyelids for that. Deep set eyes is something that's seen, as well as creases in the, underneath the eyelids. And then other manifestations, so blepharochalasis, which is where you can have repeated episodes of swelling of the lids, leaving the skin sort of thinner and slightly more papery than it typically looks. Other manifestations that are documented for the eyes in classic EDS. So thinner cornea, so the cornea, the front part of the eye that's clear, is the thickness of it in the majority of the population, the average is about 550 microns, which is about just over 0.5 millimeter. And it's about 10% thinner in EDS or classic EDS. And that's true for other disorders as well. So a lot of the Marfan patients that we see, they will typically, again, show this sort of 10% thinning. In itself, it doesn't necessarily cause a problem, that 10% thinning. I think really where we start to care about it more is if it creates high levels of astigmatism because the corneal structure is not stable, or in fact, the cornea can actually become sufficiently thinned in parts that it takes on a more cone shape or conical shape rather than its normal rounded shape, which is something that's called keratoconus. And that can cause a number of problems. So it seems as though, at least from the literature in classic EDS, while the corneas are thinner, there's no real evidence that this translates into significant astigmatic or keratoconic problems, which is reassuring. Another thing that comes up that I'm going to touch upon again, because I think it's something of interest and importance, is there's certainly a significant rate of dry eye issues that come up, not only in classic EDS, but other forms as well. So this can be in terms of symptomatically patients describing it. So there's certain questionnaires that are given out that analyze the symptoms that patients are having. And so typically patients with classic EDS have much higher rate of symptoms compared to controls. And not only that, but when you actually look at the eyes as well as subjective measure of dryness, objective measures that we look at as the eye doctor, so the rate at which the tears break up, as well as a Schirmer test, which tests how much tear production you have, both are typically significantly less in classic EDS patients compared to controls. So a number of things that occur with classic EDS. And this actually overlaps very much as well with the hypermobile type, as well as the hypermobility syndrome spectrum of manifestations. So again, it's well published that patients can have laxity to the lids, some changes in the eyelid structures. The sclera, the white of the eye, can actually appear a little more blue than normal. The rationale there being that it's actually thinner, so the reason that you're seeing the blue is actually from the tissue underneath it, which is pigmented, and so you're actually seeing that coming through the thin sclera. Dry eyes, again, are a problem that's been recognized in the hypermobile type as well for a long time. As you'll start to see the sort of the consistency across different forms, corneas again tend to be a little bit thinner and a little bit steeper in the hypermobile patients as well. But reassuringly, again, that doesn't seem to translate to high levels of astigmatism, fragility and spontaneous rupture or keratoconus. Patients are documented as having typically higher rates of pathological myopia than control population. And neither of these are necessarily surprising because certainly the extracellular matrix is recognized as being somewhat altered in many connective tissue disorders. And so I think it's not necessarily surprising that these changes in the cornea, as well as the myopia from the sclera, the white of the eye, allowing the eye to elongate more than normal, it's not surprising that they occur. Again, very much along the lines of with the classic EDS, so hypermobile EDS are frequently seen a high rate of dry eye issues, both subjective measures of patient complaint, as well as objective measures that we talked about before, that tear breakup time, as well as Schirmer testing. And I think a theme that's going to come up a couple of times today is, I think what's interesting about these is that if you actually look at what produces tears, it's actually driven by one branch of the autonomic nervous system. And as everyone is, I'm sure, acutely aware with the autonomic changes that can occur in EDS, I think this and other manifestations, I'm going to go on to speculate there may be a physiological basis for it. So in terms of a few of the other things that we tend to see in patients that I don't necessarily see documented as extensively in the literature. So one of the things we not infrequently see is something we call accommodative insufficiency. So what that essentially means is accommodation is the ability of the lens inside the eye to change shape to allow our eyes to focus not only in the distance, but then look up close if we want to read something, a book or a phone or something else. And so this is really represented here. When you're looking at something in the distance, the rays of light that come into the eye are almost parallel. And so if the eye is relatively neutral, so it's not nearsighted or it's not farsighted, then between the cornea and the lens, they will focus the light on the retina and allow you to see clearly. In order to focus up close, as you can see, compared to the parallel rays that were coming in when you look at distance, now these rays are not parallel, they're coming from a point here that's actually diverging. So the eye has got to work harder in order to be able to continue to focus this light on the retina. And the way that it does that, the cornea can't change shape on a moment-to-moment basis, but what can do is the lens. So the lens will become more round. That'll make it more powerful, and that will allow the eye to focus better. Now, if you have an insufficiency of this, it essentially means you have an impaired ability for the eye to actually be able to do this. And so typical symptoms may be blurring of vision. If you're focused for an extended period of time, either reading, studying, even computer work is not quite as up close, it's more here, but the eye's still got to work harder to do it. And as the eye is having to work harder to do that, then that can often manifest as associated headaches with a sort of feeling of strain and with prolonged reading. So if one is farsighted, so what that actually means is when you're farsighted, it means that in fact you have to accommodate to some degree the entire time. Even to look at objects in the distance, you have to accommodate a little bit. And then to focus on objects up close, you have to work really, really hard. And so sometimes in people who are farsighted with EDS, they can even have issues even just seeing in the distance, because that ability to accommodate to even see clearly far away is hard to do for prolonged periods. Now, the flip side is if people are nearsighted, what that actually means is if you're nearsighted, that means that your eye naturally focuses up close. So it actually doesn't need to accommodate in order to be able to see something close up. So in patients who are nearsighted or myopic, this tends to be less of an issue because their eye is naturally focused and relaxed when they're reading rather than having to accommodate to do it. However, what I will say in patients sometimes, if they wear glasses, it's not necessarily a big deal because the glasses will allow them to see at distance. And then they just take their glasses off and the eye naturally focuses up close. The slightly greater challenge comes when they want to wear contact lenses, because the contact lens will take the place of the glasses being able to see clearly at distance. But then in order to see up close, they can't keep taking their contact lens out every time. They have to undergo this accommodation process in order to overcome the contact lenses to see more up close. So switching between glasses and contact lenses can sometimes induce this issue in patients who are nearsighted. So if we refer back to what I mentioned briefly before, so I think what's interesting in POTS is the fact that you do get these abnormalities in the autonomic nervous system. And I don't wish to insult anyone's intelligence, but just to make sure we're all on the same page. So the two main branches of the autonomic nervous system are the sympathetic, so the idea of a fight or flight. So you get an adrenaline rush and it primes your body to either, I guess in evolutionary times, to fight off an attacker or to be able to flee rapidly and outrun them. The other branch is the parasympathetic branch of the nervous system, which essentially makes everything relax. So sphincters in the body relax, it slows the heart rate, and it has a number of effects on the eye. So interestingly, one of the things that the parasympathetic system does, we talked about before, was tear production, which I think certainly could underpin some of the reasons of the dry eye issues that patients have. Now, interestingly, the parasympathetic system also controls this ability to accommodate. So again, it may be another common link between another manifestation we see with patients and a connection to indeed the autonomic nervous system. So how do we normally evaluate patients to see if they have accommodative insufficiency? So we do something called dynamic retinoscopy. And so what you may see your doctor do is hold up a retinoscope that looks like this, and we'll shine it into your eye and we'll move it back and forward across the eye. And depending on the reflex that you get, it will tell us whether, if we'll get you to look in the distance and we'll shine it in your eye to look for a certain reflex. And then we'll often get you to look up close. And then again, shine it again to see if your eye, we can actually see the lens in your eye accommodate by the reflex change that occurs. And if patients have an inability to accommodate, that we will actually be able to see the eye struggling to actually go through that accommodation process. Now, from experience of this, what I will tend to say is that I tend to feel that patients do pretty well on this test. It's almost as though with a focused effort, EDS patients are able to at least temporarily achieve this accommodation that they need to. Yet it seems that there's clearly many patients have manifestations, and I think that's probably reflected in the fact that, for a prolonged period of time, it gets harder for EDS patients to accommodate. And because this is just a transient test that we test just briefly, I don't think it probably fully captures the challenge that patients have. Something else that I tend to find is potentially a little more useful. So another scenario where we have a reduced ability to accommodate and look up close is with aging. So for anyone who's in their 40s or 50s or beyond, you'll know that as you got older, you needed some cheater glasses in order to be able to read up close. And that's really because exactly the same, not quite exactly the same process, but the same principle. So what happens as we age is the lens loses its suppleness and loses its ability to change shape as much. And so as you get older and the lens can no longer change shape to focus up close, then you need a pair of over-the-counter readers to supplement it. And so actually in patients with accommodative insufficiency, something that I'll sometimes try is I'll say, well, look, you know, the dynamic retinoscopy that I've done, it doesn't really show me what I think you probably have. So let's actually do a diagnostic and a therapeutic trial. So go away, get some over-the-counter readers, and then just use them for a while and see if that actually helps with the symptoms you're having, the blurring of vision and the headaches, with this prolonged reading. And what I'll often say is, you know, if you want to get a +3 because they're stronger, that may actually help diagnose it better, because hopefully it will maximize the improvement in your symptoms. And then for the most part, if you find that that does indeed help, that diagnostically tells us, yes, that's probably what could be going on, but then let's try something that's less powerful, maybe half as much, maybe a +150, in order to actually to use longer term, because the idea being that if +3s are doing all the work for your eyes, then that's really stopping your eyes doing any of that accommodative ability. We don't want your eyes to become dependent on the glasses. So using something that's less powerful, hopefully helps get rid of the symptoms, but still requires your eyes to do some of the work so that it is still accommodating. Another couple of things I will just mention. So a question that some patients will ask me, they'll say, well, you know, if this is a problem with my autonomic nervous system, for my POTS, I use a drug like midodrine. Will midodrine help for this as well? And what I tend to say is I think it's unlikely to do so, because in the eye, we talked about the two branches of the autonomic nervous system. So you have the sympathetic branch and the parasympathetic branch. And the sympathetic branch does a number of things in the eye, but none that really seem to manifest in EDS patients that I've tended to see. Maybe the ptosis a little bit, the drooping of the eyelids, but for the most part not. It seems to be the parasympathetic system where patients have multiple problems in their eyes with EDS. And because midodrine tends to work on the sympathetic branch, I tend to feel as though it doesn't necessarily help with the symptoms that many of my patients complain about. Now, there is a drug that can be used in a different setting to actually help with supplementing accommodation and allowing people not to have to accommodate as hard. Some people use it. I tend not to use it a lot because it can cause things like cysts in the iris, so the iris being the colored part of the eye. And there can be issues if you're undergoing surgeries with general anesthesia. So one has to be careful if one is using this, but that may be something that patients wish to consider. So another related issue that we tend to see in patients is something called convergence insufficiency. And actually this is documented in the literature that a significant number of EDS patients actually are often found to have this. And so what convergence is when one looks in the distance and the eyes essentially look straight ahead because the light coming in is parallel, when you actually focus up close, your eyes actually have to turn inwards slightly towards your nose to be able to see an object that's closer. So as opposed to what we talked about before was the eyes focusing using the lens in order to accommodate, but in this case, it's the eyes actually turning in, but part of the same process. So in fact, there's something that we call the near vision triad, where you have not only accommodation, which we talked about before, but also convergence, the eyes turning in, and then a third part that we'll be coming to next as you start to see the connections between the different things that I'm talking about today. Because interestingly, all of these are actually driven by the parasympathetic branch of the autonomic nervous system. So in this case, what can happen if you have a reduced ability for your eyes to turn in or converge is that, at least in adults, if the eyes do not turn fully in, one eye may be looking just here, one eye may be looking just here, and what you'll end up doing is seeing two objects or getting double vision, where the eyes are not focused at the same point. So you see two of the same object, and if the eyes work really hard to try and overcome that and bring it together, that can manifest as headaches with prolonged near work. Because there's overlap between convergence and accommodation, then you can actually see both of them together. So patients may have blurring from the accommodative insufficiency or double vision from the convergence insufficiency with prolonged near work. In terms of how we test for convergence insufficiency, so there's a way, essentially we call it amplitude testing, whereby we use little prisms that we'll talk about in a few minutes to actually measure how strong the ability of the eyes to turn in is. And so typically when someone in the general population looks at near, they're able to turn in about 38 prism diopters at near and about 14 at distance. And in many of the EDS patients that we see, even in some who don't necessarily have manifest symptoms, this can really be reduced by 50% or more. And in some cases, it's dramatically reduced. So it can certainly be a significantly lower in EDS. So how does one treat or try to counteract convergence insufficiency? So one of the ways is essentially a muscle strengthening exercise. So the idea is that you have a muscle on each side of the inner aspect of each eye that turns the eye in, and one on the outer side that turns the eye out. So these muscles that turn the eye in, you can almost do like a weight training gym exercise for them, in the same way that if you wanted to build up muscles in the rest of your body, then you can regularly exercise them and try and push them to strengthen. And so here's just one example of the concept behind this, that if one looks further away, then the amount the eyes has to turn in is a certain amount. As one starts to look a bit closer, the eyes turn in more, and then looking really up close, then the eyes have to turn in even more. And so the idea is, by going through this series of training, there's both online forms of this as well as offline forms, then the idea really is to strengthen those inner muscles to help turn the eyes in better. I will say anecdotally at this point, it's something we're looking to more formally quantify, but I tend to feel as though I've been slightly disappointed in the response of many of my EDS patients to this convergence training. And I think this is purely speculation at this point, but could one make the argument is the pulleys that actually hold the muscles in place in the orbit, are they excessively loose or lax? It doesn't seem infeasible that they might not be. Or are they located in some slightly different location as to why this exercise muscle training just does not achieve as good an effect? I think that's one theory as to why this may occur, or I would throw out another one as well, that if indeed this is part of an autonomic nervous system problem, in the same way that if you wanted to exercise a leg to build up the muscles that are stronger, if you have a problem with the nerve that actually controls the muscles in the leg, it's much, much harder to overcome a neurological weakness simply by trying to strengthen muscles. So I do admit at this point this is purely speculation, but it's something we've certainly thought about as we see many of our patients. So another thing I wanted to touch upon that I don't necessarily see hugely discussed in the literature is light sensitivity that a number of our EDS patients seem to possess. So there's a few different terms that we talk about within the ophthalmology field. So the first one is photophobia. So this is really a sensitivity to light. So looking at light hurts, but you're still able to see, it's just uncomfortable. This compares to hemeralopia, where you actually can't see as well in bright lights. It doesn't necessarily hurt, your eyes are not able to see as well. And then to a third concept where we talk about photobleaching, in terms of it's not just an inability to see as well, but it's almost like when you look at certain light, it bleaches out your eyes, and then you have to wait a period of time before you can even see anything else. So that's considered more photobleaching. And I think something that I've noticed over time as more and more patients have come in discussing this with me is that it seems that EDS patients pretty uniquely compared to other patients we see complain of a real problem with fluorescent lights as opposed to more normal incandescent lighting or sunlight. So it really seems to be those higher intensity fluorescent lights that a lot of the patients that I've had complaining of this light sensitivity seem particularly sensitive to. And so, what we'll typically do, as with all patients with or without EDS, on clinical examination, one of the things we look carefully for is something called transillumination defects of the iris. So the colored part of the eye, it's there partly to block out excessive amounts of light getting into the eye. And that's why your pupil in the center there changes size. So when it's dark and you want more light to get into the eye to see better, the iris will contract and the pupil will get bigger to let more light in. And then when you're in the bright, then the pupil will get smaller to reduce the amount of light that comes in. And so some patients, for example, in albinism, who have a very thin iris and these so-called transillumination defects will have a sensitivity to light simply because there's too much getting into the eye. Now, really, I don't see that frequently in EDS as an explanation for this light sensitivity. Sometimes what we will see in some patients is that they will have very large pupils in EDS, and they tend to not shrink down as much as many. Now, this is something you can occasionally see in the general population, but I would say I've seen it to a larger degree in my EDS patients than in the general population. And interestingly enough, not that I wish to harp on exactly the same theme the whole time, but interestingly, actually the parasympathetic system that we talked about before is actually what's involved in constricting that pupil and making it smaller. So you could even theorize that a deficiency in this, as well as contributing to the accommodative insufficiency and convergence insufficiency, a deficiency in this may, in some EDS patients, it may indeed be that any deficiency in the parasympathetic autonomic nervous system may explain why they have slightly less reactive pupils, and that can result in letting more light in. Although I think for the majority of patients that I see with this complaint, I don't think this does explain it. And so typically when patients come in with this, there's a number of things that we will do. We'll typically look at the anatomy of the retina to make sure that anatomically it looks normal. And I would say in most of my EDS patients that have this, it does. Another thing that we do is something called a photo stress test. And it's actually conceptually very simple. You will take a regular light that we use to measure whether someone is near or far sighted and shine it into each eye individually for about 10 seconds. And then we'll see how long it takes the eye to recover to be able to read as well or nearly as well as it could before. And the idea being that if someone has a retina disease, then there can be a delay in their ability to actually recover and be able to see as well as they could before if they have a retina issue. Now, interestingly, I would say in most of my EDS patients who have this issue, their retina looks absolutely normal. Their photo stress test is absolutely normal. And the other test that we will often do is an electroretinogram. And that is almost like, I call it an EKG, but for the eye. So we'll shine a light into the eye and we will detect an electrical signal back from the retina to tell us how well the retina is functioning. And I would really say in most of my EDS patients, they do absolutely fine with these, but they still have this significant sensitivity to these fluorescent lights. So things that patients can try. So one thing, if you do have large pupils and it may be letting too much light in, you can actually try medications that reduce the size of the pupil. So brimonidine.
The other thing to consider is using sunglasses. The thing about sunglasses is if one actually looks at the visible spectrum of light based on the picture on the top right here, and the various wavelengths of light that one sees all the way on the left-hand side from the blue, purple, lower spectrum all the way up to the reds, typically standard sunglasses will simply reduce the brightness across this entire spectrum. And therefore the spectral composition, so to speak, stays the same. Everything is just lower. The other option to consider using is selective filters that just filter out certain wavelengths of the spectrum. And so given that the fluorescent lights typically fall more at the purple lower end of the spectrum or the left-hand side of the spectrum that you've seen there, this falls more towards the ultraviolet range of the visible spectrum. And so sometimes patients have had success with things like arc welding glasses and other similar type lenses that tend to actually block out light more in that lower frequency range, higher frequency, lower wavelength range without targeting some of the other ones that they're not as sensitive to. One thing I will also just mention is one particular agent that some patients are put on for POTS for their EDS, so either braiding. If you haven't been told or if you're advised to go on it, something to bear in mind is that the particular channel that it targets in the heart to have the effect of it does of actually slowing the heart rate down. Interestingly, the other place in the body that that channel exists is in the retina, in the eye. And so about 20% of patients will actually have visual changes, blurring of vision, something described as luminous phenomena, as well as visual brightness. We have a patient who started on this and their ability to see in the dark appeared to change as well. And so I think that's just something to bear in mind if you do have new onset of vision issues, to just make sure it doesn't relate to that particular agent. And Sarah, can we go on to the next slide? Okay.
Yep, we are on the correct screen. Yep.
Wonderful. Okay, so another thing that is described in EDS is something called angioid streaks. It was described over 50 years ago and has classically been considered a classic manifestation of Ehlers-Danlos syndrome. And it can either be noted incidentally, looking in the eye and seeing it there, or it can be as a result of the problems that occur. And so when we look inside the eye, and if you look at the retina on this right-hand side, I can't show it now with a laser pointer, but you'll see these cracks, these lighter lines that appear in this mosaic pattern that spread out from the nerve and actually almost appear like cracks in the retina, where actually one of the membrane towards the back of the retina does indeed have breaks in it. And so what can happen is that blood vessels can grow up through these cracks and actually bleed inside the eye. So sometimes these cracks are noted incidentally. Other times it can actually be a result of the problems from the blood vessels that occur. So interestingly, we did a study of this, Eric Sigman and myself, actually came out last year, that really showed that none of the EDS patients that we were seeing appeared to have this manifestation, which was surprising considering it was considered a manifestation of the disorder for half a century. And actually another group in Moorfields in London looked at a number of their EDS patients as well and found much the same thing. So I think it's maybe slightly more questionable now whether this is a major feature in EDS, which I just mentioned here. Given I'm aware of the time that we've lost a little bit of time because of some of the technical issues, so I'm going to just skip through a little bit. But some of the other eye-brain related issues that we see in EDS patients, sometimes blood flow issues to the brain or the eye can cause some lightheadedness, dizziness, and associated changes in vision. And sometimes this can relate to transient episodes of insufficient blood flow to the retina, nerve, and the brain. So at this point, chat, we're on the slide that says neuro-ophthalmic manifestations. Just making sure that that's what's up. And then if we advance, the second point on this slide is that patients can also be predisposed to traumatic brain injury related complications. So again, this is something that Eric Sigman has an interest in, and he's shown that a lot of EDS patients have a slower and less complete recovery from traumatic brain injury than many patients without EDS. If we advance to the next point, so several other neuroophthalmic manifestations that we see in patients as well. Things such as visual snow is where it's almost like a static that appears in the vision that's there in both eyes and can be there the whole time. Something else we call palinopsia, where there's a perseveration of the image so that you will see an image of something, and even when that thing has disappeared from the vision, the image of it is still there. Again, these are unusual things to see in the general population, but certainly these are things that we have seen repeatedly in our EDS patients. If we go on to the next slide, it should say strabismus. And intermittent exotropia is a form of eye misalignment that we see probably most commonly in our EDS patients. And this overlaps to some degree with what we were talking about earlier with the convergence insufficiency, whereby with the convergence insufficiency, the eyes were able to look straight in the distance, but just had impaired ability to turn in when looking at close. In exotropia, what it essentially means is that the eyes are turned out both in the distance and at near. And so this can typically manifest as a double vision, which can be present distance and near, and it may be more so of a problem at near. It can be intermittent, so sometimes it's there, sometimes it's not. And then things such as fatigue, stresses, other illness, or age can all make this worse. And so what we will typically use is there should be a picture of a prism on the right-hand side. So we will quantify the amount of that the eyes are deviated using prisms. And then if we just advance to the treatment part of the slide, then there's a number of things that we can do to treat. So in children, we can use something called over-minus glasses. We can use a stick-on prism, which is called a Fresnel prism, over a pair of glasses to help try and realign the eyes. Sometimes we can actually build prism into glasses so that it's unlike the stick-on prism that makes the image a little bit blurry. The ground-in glasses, it just looks like a regular pair of glasses, other than the fact that they can be a little bit thicker and heavier. And then in terms of, there's always the option of surgery that we do. And what I generally say for the surgery when I do this is there's a few different ways to do the surgery. And I think having done this now on a number of the EDS patients, there's certain nuances to it that I think one can use as a way of getting better outcomes for patients, not only in terms of the type of the surgery, but also the amount of surgery and the use of something we call adjustable sutures, where we're able to tweak the surgery for up to 7 days after the surgery to try and get it as good as possible for them. If we say next slide, this should show other eye surgeries in EDS, which is coming towards the end here. So we had done at Wilmer a survey of a large number of EDS patients, very kindly coordinated with the EDS Society. We had 467 confirmed cases of EDS. The majority were hypermobile. And of those, about a quarter had eye surgery. Intriguingly, about 3/4 underwent eye surgery before they had actually had a diagnosis of EDS. And about 50% reported some form of issue following the surgery. So there were several different things: refractive surgery, the cataract surgery, retina surgery, strabismus surgery. I won't go through all of these now, but we can certainly address people's questions as they want. And I think the general conclusion from the study was that EDS patients tend to require the same sort of surgeries as the regular population. They tend to incur similar issues afterwards. And then I think, is it at an increased frequency? I think that's slightly open to question because of the nature of the survey. people that have issues may tend to respond more. So I think that's still somewhat unanswered at this point, but is at least a possibility. And then the final thing I wanted to touch on, if we go to the next slide, which should read post-operative course at the top, a final thing I wanted to touch on that I've noticed over time anecdotally myself is that, particularly with the strabismus surgeries that I do, I tend to feel as though the EDS patients that have a mast cell activation syndrome, it appears as if they have somewhat more of an inflammatory response than I think many of other patients without EDS that I operate on. I don't know if this relates to the response to the surgery itself, perhaps the sutures that we actually use during the surgery. And so typically with patients with this, I would tend to minimize the suture use as best as possible to try and reduce anything that incites any inflammation. And I'll often tend to use a longer course of steroid drops as well to help dampen down that inflammation. So if we go to the next slide, that should just say thank you and questions. My email is there. People are welcome to reach out to me if there are specific questions they have. Otherwise, I'd be happy to take any now. And I'm sorry, I know we've run a bit longer than we planned to.
Thank you so much, Dr. Doyle. And I am fine if you're free with sticking over a little bit and making sure we get all the questions answered. Let me pull up some of them right now. Our very first question is entropic surgery known to be successful with EDS and HSD tissues?
Sorry, entropian surgery?
Entropic? Let me double check and clarify that. It says entropic.
And I'm assuming entropion surgery, unless I'm misunderstanding.
If that was your question, can you clarify, please? We would appreciate that. And we'll get back to that one. Sure. The next one is refractive surgery effective on people with EDS? And is refractive surgery the same as site corrective laser surgery? And is it safe with classical EDS?
So I think something to think about is what we touched upon earlier, that patients with EDS, including classic, can have a cornea that is somewhat thinner. And so compared to the population average of about 550, it may be down in the 500. Now, that's obviously a mean, right? And there's a range either side of that. But something when thinking about having that type of refractive laser surgery is the fact that the cornea has to be a certain thickness in order to be able to do that. You can't make it too thin. And so it really depends on the numbers that you have. But I think that's certainly something that should be carefully analyzed and discussed. I think another thing to think about is the laser refractive surgery can increase the dryness of eyes. When one actually cuts through the outer layer of the cornea before doing the remodeling, then that actually cuts a number of the corneal nerves that reduce the amount of tear production. So for someone who has significant dryness already, if that's a manifestation of your EDS, that's something that you want to think carefully about as well. So as I will probably end up saying repeatedly with these questions, and not that I want to sound like a broken record, but it's sort of case by case specific and partially also the type of EDS you have. But there are a couple of things that I advise patients to think about carefully.
All righty, thank you so much. Our next question is, I am 69 years old and diagnosed with low tension glaucoma. I had a KDB goniotomy after a trial of drops and cataract surgery that helped, but pressure is back up from 10 to 17 and the left eye is worse. One doctor wants to do an SLT, another disagrees that it won't work due to the goniotomy. Any advice is very much welcome and appreciated.
Okay. So again, I think that's a highly specific example that I don't know will necessarily relate to a lot of people. I guess sort of general concepts are the goniotomy, as you describe, is sort of a physical attempt of opening up of the drainage system of the eye to allow the fluid to flow out better. I guess the idea being that the SLT, as you describe it, is using a laser to effectively do something similar. So to actually, people slightly disagree on the mechanism by which it works, but broadly speaking, you can think of it as either punching holes in the filter system to try and open it up, or actually causing some inflammation and allowing it to remodel. So I would probably say it depends. If the goniotomy was 360 degrees, so all the way around the drainage system, then I would agree that the laser, which is often 360 degrees as well, may be less effective. If the goniotomy was only a small part of the drainage system, and then a lot of the drainage system remained untouched, then maybe there is an opportunity. But I would say if you're talking about pressures in the 10 range to 17, it can often be hard to get a pressure very low, more down towards the 10 to 12 range by just doing that laser surgery. But again, I think if you're in the hands of a good glaucoma specialist, then I think they should be able to advise on that.
All righty, thank you so much. And clarification from our first question, entropion is correct.
Okay.
So is entropion surgery known to be successful with EDS and HSD tissue?
So I guess part of the, and was this the patient you said was 69, or that was the glaucoma patient?
No,
was it? I'm getting
the 69-year-old was the glaucoma one, yes.
Okay, sorry. So I guess the general concept here is an element of laxity of the tissues. I don't know how old the patient is with the entropion. So conceptually, this is not uncommon in the general population as well, particularly as one ages. And the general concept is that a laxity of that eyelid, typically the lower eyelids, actually cause, and an instability. There can be different things. Sometimes it can relate to trauma, certain chemical use, burns. Sometimes it occurs spontaneously. All of that factors into how successful this is and how one does it. I'm going to work on the basis that it's the simple form that tends not to be secondary to something else. And so that laxity in the tissue that you really need to essentially try and eliminate some of the laxity and ensure those eyelid retractor muscles are working effectively, and if not, to get them working effectively again, I think it should be feasible to do. I don't have any evidence that EDS specific patients, this is something that is more challenging. This is not a type of surgery I tend to do, but it's also not something where I've heard patients complain of having issues with it or more adverse outcomes. So I think going to someone who is experienced in that, ensuring that they know you have the EDS, and discussing, whether they feel as though there's any nuances that they would plan to consider, I think would all be reasonable things to discuss with them.
Alrighty, thank you so much. Our next question is amblyopia or a high degree of myopia related to or caused by EDS?
So again, it partly depends on which type of EDS. But typically, as with many of the connective tissue disorders, then we do see high myopia in a significant number of patients. So if you have a strong family history of high myopia in family members that don't have EDS, it might simply be that you've inherited that as part of your family. But it certainly does occur more frequently in EDS as well as other connective tissue disorders. So I would say there's probably a fair chance it does relate, at least to some degree, to your EDS.
All right. Next one is, have you seen, no, that's the wrong one. In hypermobile EDS patients with glaucoma, have you seen an increase in disc hemorrhages and thinning of optic nerves compared to your patients without EDS? And that is hypermobile EDS.
I would not say it's something that I have seen a marked increase in. That is something I've seen frequently enough to really make me think twice about it. I think the presence of disc hemorrhages, many glaucoma specialists will say, may reflect an acute insult to a particular part of the nerve, and therefore a nerve under stress, for example. It may indeed be a sign of an acute change in progression. And so I think something to think about. There's work that has been done by Harry Quigley out of Walmer, looking at stress of the and sclera, composition of the white of the eye, the sclera, actually at the optic nerve head, which is where these hemorrhages are occurring, and actually looking to see if changes in scleral composition can actually influence the stress in which the nerve is under. And so could one hypothesize that any change in scleral composition in an EDS patient may place added stress on the optic nerve, leading to these focal hemorrhages? Hypothetically, yes. I think in practice, I don't think we have the evidence, or at least I'm not aware that someone has published evidence to say that's definitively the case.
Thank you so much.
I should add, I was going to say, certainly I should add that it does occur in the general population as well. So I don't think that's an EDS unique feature.
All right, thank you so much. Are there any considerations to take in when dealing with Fuchs dystrophy and cornea replacement?
So here we're really talking about the inner layer of the cornea. So Fuchs dystrophy, where endothelium, so the cornea, the clear part of the eye, has essentially 5 layers. And this is the innermost one that's on the inside of the eye. And so when this starts to fail, as occurs not infrequently in the general population, then the cornea can become hazier, particularly more so of a morning. And I think, not that I have seen specifically, I would say it depends on the type of surgery being considered. So historically, in previous decades, the entire thickness of the cornea would be replaced. Nowadays, there's techniques where just the inner layer of the cornea is actually replaced, or the inner 1.5 layers, let's say. And so I think I have no real evidence that there should be issues with that in EDS patients more so than the general population. I think having someone who is experienced and doing it well, I think you should be in good hands with that.
All righty, thank you for that clarification. Going off of your information on dry eyes from earlier in the presentation, could clinical manifestation of lacrimal keratoconjunctivitis without any pathology be ANS involvement due to EDS?
Sorry, lacrimal keratoconjunctivitis. Was that what you said?
Yes.
So I think it partly depends on what exactly has been found. So if the lacrimal gland appears just to be not functioning as well, as in not producing enough tears, then I think certainly that could be there could be a feasible link, as we talked about before in the presentation. I think if the lacrimal gland has been biopsied and there's any evidence of inflammation or infiltration or any other atypical features with that gland, I don't think that would derive specifically from just a increased autonomic input to the gland. But working on the basis that we're not talking about a biopsy process, and we're just talking about the dryness of the eyes and the conjunctiva as a result of that, then I do think that is feasible, yes.
All righty, thank you so much. Do surgeons need to take special precautions with vitrectomies and cataract surgeries in EDS patients? And I guess overall, other than the point you brought up about the mast cell possibly playing a role in not healing, are there other considerations that surgeons should take into account before surgery?
So I think with regard to vitrectomy per se, I think there is some, I think certainly if patients are highly myopic or highly nearsighted, you know, I think that trends to stretch the retina a little bit more and increase the risk of there being naturally occurring little holes or breaks in the retina. But I think any retina surgeon doing the surgery should be well aware of that process and well able to deal with any consequences of that. I don't think necessarily in the majority of cases of EDS, I don't know that one specifically needs to do anything different in that sense. The surgeries that I tend to do that involve actually going into the eye, really on all my connective tissue disease patients, I'm very careful about closing all suture holes, all penetration holes. So particular types of cataract surgery that we do sometimes involves going into the vitreous cavity as well. With very small instruments, sometimes people tend not to close those holes, including with cataract surgery. With any of my connective tissue patients, I just will always put in a suture and make sure everything is nicely sealed shut, just because I do worry slightly that any laxity in tissue or any weakness in tissue can just predispose to leakage of wounds and loss of pressure of the eye. I don't know of definitive literature actually proving that, but I think that's more anecdotal experience of patients coming to me and saying that it happened to them. And myself, I'm just overly cautious about it. I will always make extra effort to close those, and it's never proved to be a negative doing so. So I think whether it's cataract surgery, whether it's vitrectomy surgery, I think just ensuring having someone who feels confident in dealing with connective tissue disease cases and who is cautious and knows the potentially added risks associated with it. I think as long as you find someone who is in that position, then I think you should be fine.
Thank you so much. Now we've had a few questions in on this topic. Does capsular tension rings help keep the lens in place in individuals with hypermobile EDS? And is that a treatment you would suggest?
So what we're really talking about at this point is the lens itself and the zonules. So the lens typically sits in a bag inside the eye, and that eye is suspended to the eye wall, almost like spokes on a bike. It's suspended using something called the zonules, which holds it in place. And so in certain connective tissue disorders, such as Marfan syndrome, for example, you can get significant displacement of the lens and zonular weakness, either diffusely or more in one part of the eye. In an EDS, certainly their lens dislocation, or ectopia lentis, as we call it, can occur. I would, so in terms of it, I would say it again, it's a case-by-case basis, depending on is there any frank evidence of lens displacement? Is there any frank evidence of zonular weakness? I think I tend to be quite cautious. I tend not to put in a capsular tension ring prophylactically. I don't know if there are others out there who do so. I think in terms of if there is any zonular weakness and one wants to use a capsular tension ring just to try and support it a little bit, again, it partially depends, I think, on the degree, the extent of it and the severity of it. So I wouldn't necessarily be able to say in every case. My only experience, I would say, and particularly with my Marfan patients, is I have had a number of patients where people have thought the zonules were stable enough to put a lens inside the existing bag, and that's not necessarily proved in the longer term to be the case. So I'm certainly cautious about doing that.
Alrighty, I'm going to do my best with this pronunciation for our next question. Have you seen patients that have EDS with Thygesson's disease? I also have POTS and mast cell, but looking in the community, I have yet to find somebody else mention this.
Yeah, so Thygesson's is a particular corneal feature where, assuming that we are talking about the same thing, where you can have, it almost looks like little snowflakes that occur on the surface of the cornea. And so sometimes they'll sit there under the surface and be quiescent and not cause any issues. And sometimes they'll just break through that outer layer and actually cause significant irritation and discomfort. And I would say that's not a feature I recall seeing in any of my EDS patients in the past 5 years. I am not aware that it is described in a higher frequency in EDS. I'm not sure I could speculate as to a mechanism how it would be if that were true. And so I would be tempted to say it might simply be that you just have the co-occurrence of two things. Certainly we'd see a number of patients with Thygesson's. And so I would be delighted to be proved wrong and discuss further if you feel there is a connection, but it's not something I've seen as a co-occurrence typically, no.
Alrighty, thank you so much. We've got time for 2 more questions before we need to free up this line. The first is, I had an ERG and it was excruciating. How do I explain to my neurologist and retina specialist that I'm able to pass these tests but still might have this problem?
So I'm not quite sure the reason why the ERG was done. I think, I don't know if it was because of a sensitivity to light. I think patients with other retinal conditions, so something, when there's a problem with a certain type of cell in the retina called a cone photoreceptor, then we may do an they may be particularly sensitive to light, and we may do an ERG to try and show whether or not those cones are dysfunctioning. I'm hypothesizing here now based on the question, but if that is the case, then it sounds very similar to what I've seen in patients who have a sensitivity to light, but they appear to have a normally functioning retina, but they do have this degree of sensitivity. So I think if that does describe the person asking this particular question, I think similar to the slide that we talked a little bit about, I think there may be other tests that we have to develop that more accurately reflect a test of the symptoms our EDS patients are having. So one thing I sort of put on the slide but didn't end up touching on because we were running a bit behind was this sensitivity to certain frequencies of light. I almost wonder whether we've talked about this within our clinic about developing tests that are specific to certain frequencies that may be more reflective of the challenge that EDS patients have. Certainly, I'd be happy to discuss that further if you feel as though that is something that may be relevant to you.
All right, thank you so much. And lots of comments of thank you so much. And just a couple of people wondering if they can come to see you for an evaluation for eye issues.
Yeah, so I think as Sarah, you very kindly said at the start, you know, I have a genetic eye disease clinic every week at the Wilmer Eye Institute. I'm certainly happy to see any patients that feel that they fall within that category. I think I will defer to the schedulers, and I guess with the strange times that we're in about availability of time slots, or people are welcome to reach out to me rather than necessarily automatically traveling a long distance if they have a specific question that they're looking to be addressed. If we're able to address it in a way that doesn't require them traveling across the country or state to state, then I'm happy to try to facilitate that if we can.
Alrighty, and just one more time for chat. The institute is Wilmer Eye Institute?
Correct, yeah.
Alrighty, thank you so much. But yes, thank you so much. I'm so sorry we had so many tech issues, but with everything going on, I am thankful for everybody here for sticking with us. I'm thankful to Dr. Doyle for jumping over all of these barriers just to get out here and talk with us today. If anybody would like any more information, especially if we weren't able to get to your questions, please check out our website for more resources and information. Give our free helpline a call or an email, and they will help find answers for you. And if they can't find answers for you, they will find somebody that can help you. I totally recommend them. They're amazing people. They do a great job. And definitely consider signing up for our newsletter if you haven't already. It's a fantastic source for the most up-to-date information and upcoming events.